Chairman Carpenter won't be here today, so we'll go ahead and move on. We have the first item of business is approval of minutes from January 28, 29, 30, February 3, 4, 5. Has everyone who's wanted to look at those had a chance? Is there a motion to approve?
I so move, Mr. Chairman.
Representative Blex, motion to approve the minutes. Second by Representative Ellis. All those in favor, say aye. Aye. Those opposed, no. The minutes are approved. I want to say welcome to committee to Drew Adkins. He is from the Kansas Department of Aging and Disability Services. He's here first to give us a presentation on the 988 suicide prevention hotline. Thank you.
Thank you, Mr. Chair, members of the committee. Can everyone hear me okay? Good, okay. Thank you from myself and from KDADS to be here today to talk about the 988 Suicide and Crisis Lifeline. I think we've got maybe around 8 to 10, maybe 11 slides. I'll go over them. We do have a lot of data in those slides just to make the committee aware. I'm happy to continue through the presentation and do questions at the end if that's amenable to the committee and to the chair. So we'll start on slide 2, and I think this is my job here, so maybe, there we go. We'll start with what is 988, and if you're not familiar with 988, again, we're happy to provide some awareness for you today. So 988 is the dialing code to connect to the National Suicide and Crisis Lifeline. You may have heard of this before July of 2022, and I'll talk about this a little bit more in my subsequent slides, but this used to be called and still is nationally somewhat known as the National Suicide Prevention Lifeline. So that's another name is also known as. So this is a line that anybody can call. No matter if they have a payer source or insurance or not, they can call. It's absolutely free for them to connect with a dedicated, compassionate, and accessible, highly trained support for crisis care if somebody is in a mental, behavioral health, or substance use crisis. We packed in a lot of different information here about the history and implementation. I won't read this verbatim, but I do want to hit a couple of points here for the committee. I mentioned this just a few moments ago that the 988 Suicide and Crisis Lifeline was implemented nationally and in Kansas on July 16th of 2022. 988 is currently answered by 5 different centers. So we have centers that answer for their counties. Those centers are in Wyandotte County, Sedgwick County, and then in Johnson County. And those are answered by our certified community behavioral health clinics. So in Wyandotte, that would be a Wyandotte Behavioral Health Network. In Johnson County, that would be Johnson County Mental Health Center. And in Sedgwick, that would be ComCare answering their calls for their county. On top of that, we have Headquarters Kansas, which is our main 988 call center for the state. They answer the rest of the 102 counties for the state, for the balance of state. So they're our main call center out of the 5. And then we also have a backup Health Source Integrated Solutions that answer a lot of our rollover calls, chats, and texts. And I'll talk a little bit more about that here in just a few moments. So 988 is overseen by the federal agency, one of our main partners at KDADS, SAMHSA, and that stands for the Substance Abuse and Mental Health Services Administration, and it is administered by their vendor, Vibrant Emotional Health. So zooming in a little bit more specifically for the state of Kansas and how we got here for 988, we had House Substitute for Senate Bill 19 that was enacted by the 2022 Kansas Legislature that created the 988 Coordinating Council. This council is to advise the Secretary of KDADS regarding the delivery of 988 services, development of the product, strategies, future enhancements, and also this council approves the budget for the 988 program, and that budget is right at $10 million that we have for different call center operations. We also have for marketing, the 988, making sure that people are aware of that, differentiating between certainly 911, but also between the National Suicide Prevention Lifeline and then other crisis lines that we have locally. We do receive that funding annually in the 988 fund. So since July of 2022, the system has continued to grow. We are looking to try and meet the demand and the need for services, and I'll talk a little bit more about how we measure that demand and the need for services based on the amount of calls that we get, but also looking at the quality and the instant answer rate for phone calls, text messages, and then chats via the 988 website. And I'll get to that here in just a moment. We are looking for, pardon me, in fall of 2024, geo-routing was a service that was implemented within 988. And what that means is instead of, say, myself, I call somewhere in the state of Kansas and I just get connected to someone in a 988 call center, we didn't have a way to actually route that individual to the nearest call center where they're at. So that's a great feature to have, and one of the reasons why is because if there are follow-ups needed by the local community behavioral health center or clinic and the services that are needed for follow-up to that individual, they can have a little bit more of a local connection rather than feeling that they're talking to somebody that they may not be able to get referred and connected to services later down the road. This is a slide here of just how the 988 Lifeline works. These are, want to point out, these are milestones to date for national data for 988. So if you look at this, 2 years after the Lifeline, the 988 line was implemented, the service has answered over 14.6 million text calls and chats. In May of 2024, those monthly contacts exceeded 500,000, about a third up from the prior year, and up 80% since 2022. There are some visuals there. You can see that the text that we've had, which is a good sign that some of the marketing and the dollars that we're spending to that is creating awareness among individuals for the service. So those have gone up over 1,100%. The chats have gone up 141%, and then the calls have gone up 46%. A great stat that I want to point out, too, is that the average speed to answer did decrease over 2 minutes, which is a huge deal for individuals. We don't want anybody to have to wait for that service, especially if they're in the midst of a crisis and needing more information about and needing someone to talk to specifically. And so happy to see that that has been decreased. Below that, there are some options of what happens whenever you call the Lifeline. And for example, you would press 1 to connect with the Veterans Crisis Line. When you get through those options, if you don't select any of those options, you get moved into a local call contact center that would then be, again, used through geo-routing and be closest to where you're at in the state. So these metrics here, and I can try to, I believe you have these. I know they're a little bit small on the screen, but these metrics here, zooming in from the national landscape into the state-specific landscape, are our in-state telephone, telephonic, or voice metrics. Some of the things that I wanted to point out were the originating in-state calls, so that would be up in your left-hand corner of the dashboard. We have over 47,000 originating in-state calls. We had routed in-state 37,000 to individuals that were in-state in the state of Kansas that answered those calls. I'm sorry, we had 37,000 routed in-state, and we had 33 of those 37 answered in-state. If you go down to the left-hand corner of the box, it gets a little bit more granular, and it talks a little bit more about the call flow. We have been building up the 988 system in Kansas. I would love to say that it is perfect, but it is not. Unfortunately, we have dealt with staffing woes. We have ebbed and flowed, and again, I'll talk a little bit more when we get to our in-state call rate. So when you have 37,000 calls that were routed in-state. You can see we had 33,000 of those answered, so about 4,000 less of the calls that we had. Some of those are abandoned, and if they aren't able to be answered in-state, they flow out into a national backup that is then back into the national vendor for SAMHSA to be answered to make sure that they are not hung up on or the call is discontinued. Some of the other metrics on the right-hand side of the graph is the volume answered. So it starts there with ComCare and goes through the rest of the volume answered for the 5 centers that we have. You can see that headquarters in Kansas out of Lawrence has by far the most. They have about 16,000 comparative to some of the other centers. Wyandotte Center for Behavioral Health is our newest call center to come on board. They really have hit the ground running, as you can see, with the call volume that they have. And then Health Sources, our backup, has about 1,800 there. Okay, so this dashboard looks very similar, but this is actually the dashboard for our in-state chat and text queue and the metrics there. So one of the first things that I want to point out before we go into the data is on the right-hand side, as we looked at the volume of the in-state answer rate for telephonic or telephone calls, this on the right-hand side shows just headquarters and Health Source integrated solutions. So one of the things you'll notice is the other 3 centers that we have are not on that list. The reason is because we are still building this function and this ability. It is a process. It is not something that can be stood up just immediately. It takes new staff, new development, and then also new resources. And so we do have some federal grants from SAMHSA that help with this that we just got within the past year. We're hoping to have more of those centers start to be able to answer those text and chat. We just have not gotten there. So I wanted to make sure to point that out. That's why we have those 2 centers. Mainly, again, headquarters Kansas is answering those, but also Health Source Integrated Solutions has received funding from us to start answering and being able to answer those both on the front line and then as a backup. If you look in the left-hand corner, again, that will show you the chat and text flow. So we had 17,289 chats and texts that were routed in-state. We had 10,000 that were answered in-state. 35 of those were abandoned, meaning that individual might have discontinued. And then we also had 6,900 that flew back out into our national backup. We are hoping that as we build up the program, as I mentioned earlier, that we would be able to answer more of those. Those would stay more in the state rather than go to a national vendor. Okay. These next few slides are going to look similar. Some of that has to do just with the presentation, so I won't spend a ton of time on each of them, but I'll start with this. This is our in-state call answer rate for the state of Kansas since the inception of 988, July of 2022, until December of 2024. The reason December of 2024, we are only able to get the data right now from our national vendor, and this is the last full month that we had that was available. So if we have more that does come out and the committee would like to see that in between now or has been released between now and the next time we're asked to speak, we're happy to provide that to the committee. So you'll see as we started out in July of 2022 at 84%, and we have progressed month to month, really upping those numbers. Our goal, and something that's actually been set out by the 988 Coordinating Council, is to stay above 90%. That's a really good benchmark to aim for. And I will say nationally, I've talked to other commissioners, other colleagues in my position. They haven't been able to attain this yet, so I am proud to brag a little bit on our group and our providers about that. I mentioned some of the workforce shortages and some of the onboarding, some of the things that we've had to work out as a 2-year-old program. That I don't know if that seems young or old, but that's very, very infantile, very new for programs like this. And so some of that has contributed to that and the development. I do want to note, as we get to December of 2024, we are, even though we bounced back about 3 points from 91% to 88%, we still have remained above mostly 85% since inception outside of July of 2022. So again, we do see that as a success, knowing that we will have to work harder, provide more resources, make sure that we are utilizing that 98 fund to the best of our ability for our providers. So this is a slide that takes the previous slide and the prior slide of our average monthly answer rate versus the national monthly answer rate for all states. And we wanted to visualize this. I know it can get a little bit tricky or a little bit confusing there at the end. Some of that does commingle, but we have stayed either above or really outside of May of 2024 and August of 2024, still reaching that, trying to be above that 90% and also staying above the national answer rate average. So we wanted to make sure that we visualize that for everyone. This is the same exact slide as the prior one. This is just a different way that we visualize that. It doesn't have as much of the as the line graph does. It looks a little bit less confusing, maybe a little bit less or a little bit more visually pleasing, but again shows where we're at the Kansas answer rate versus the national answer average. So this is a slide that does change a bit. This is a visualization, a stacked bar chart that we wanted to provide that shows the amount of contacts that we have based upon different months from November of 2023 to December of 2024. So we have our calls answered on the bottom portion of that, which would be most, if you're looking at that, and you would see that that's most of the way in the modality that we get communication. We also have our chats answered there, gradually growing from about June 2024 to December of 2024, where we're at 479 chats there. But also we have text, and that has been gradually growing kind of back and forth there. December 2024 is a little bit more on the rise. This is something, this slide here, Mr. Chair, members of the committee, is something that is very new. This is very recent data that we've been able to extract from Vibrant, the national vendor for SAMHSA, and so we're happy to share that today. We wanted to make sure that there was a way that we could visually represent where the 98 calls are coming in from and being answered from. And so that's what this shows. This shows the highest call, or this shows the call volumes by county. One of the things that I wanted to point out is we have a lot of the counties that have the less than 10 sign there. That means one of the things that the vendor explained to us is that they couldn't get down to below the 10 amount to get a specific amount, but it means that there were there was at least one call, but not more than 9 calls that came in from that county. So we wanted to make sure to provide a little bit more description to that. We had only one county with 0 calls there. I believe that's Wichita County. And then on the right-hand side, you can see we have the highest volume counties there and also the lowest volume counties too. And another thing on the top of this slide, this is probably a little bit more confusing, but this is where we received the calls from. This is not where they were answered, so I'm sorry, and I'll continue to provide that clarity, but just wanted to make sure that the committee was aware. Okay, so this is specifically It's the same visualization and the same map. It's just now looking at the 98 texts that were received per county in the state. And so we do have a decent amount more in this graph of not having any from those counties. I think the lowest volume counties, or I'm sorry, we don't have that, but we had 16 counties that had 0 text, but we have 59 counties that had at least 1, but no more than 9 text. Pardon me. Again, looking at the right, it seems just about the same as the calls, where we had Wyandotte County, Sedgwick County, that were hitting the top of where we're seeing the most of that utilization of the service. Okay, and so this last slide here is the 98 chats that and where they originated from in the state. Again, this is looking very low in utilization. There's a reason why. It's a newer function. Again, we're in development of that as a state, bringing awareness to that and also beefing up our providers for that service. And so you'll see there are a decent amount, 93 counties that had at least 1, but no more than 9 chats that came in that originated there. Have a few, 7 that were 0. But again, looking over on the eastern part of the state, we had Johnson and Sedgwick that were topping that list. Wyandotte was not on this list for that, but Shawnee was here. All right, and so the last data overload, I would say, slide that we have for you maybe is the contacts answered by modality. So what mode of communication we got from the individual, from the consumer, contacting the 988 Lifeline for the state of Kansas. And this is since its inception, so from Q1 of July 2022 to Q2 of October 24 of December to 2024. I believe, and I'm sorry, I am a little bit color blind. So I'm looking at the bottom there, but I believe the bottom there would be our chats answered in state and text answered in state. So maybe the red or the orange line. So you'll see that the texts have gone up. Chats have gone up a little bit here at the very end, but have consistently remained the same. Our calls still remain the main way that folks are getting in touch with our 988 service. So one of the last things that we wanted to bring to the committee today was to talk a little bit, just for a refresher for those of you that are aware, but also maybe for some orientation. And I spoke of this earlier about the 988 Coordinating Council. So the 988 Coordinating Council is responsible for giving us a little bit of direction at the commission level and at the agency level, also advising the secretary on those decisions that are made, the budget that is approved. I believe we have, I can get this too if I'm incorrect, but I believe we have around 10 members, 8 to 10 voting members of the 988 Coordinating Council. Again, we do have the $10 million in a 988 fund that we get each year to be able to spend on the crucial and necessary services for 988 and for those 5 providers, but also for the marketing of services for this for consumers in Kansas. Some of the high points, I won't go through all the bullet points, but throughout 2024, the Kansas 988 network at the request and the advisement of the 988 Council really prioritized the expansion of chat and text capabilities, trying to grow that preference for individuals that like that modality versus calling. We also looked at how can we keep providers accountable through key performance metrics and indicators. And so that's something that we continue to work on at the agency and the commission and also with the council, but also with the providers that we contract with. We also looked at what could we do for staffing challenges. who could we attract for those? What type of requirements do we have for that right now? And what could we do? As most all of you are aware, mental and behavioral health continuum on top of other areas of the state are having a lot of staffing issues. And so we don't want to be cannibalizing or eating other providers in that sense, right? How can we be a little bit more innovative? And so we continue those discussions to try and see if we can cut any tape for that, provide a little bit more ease of access for individuals that would like to be involved in this service, knowing that sometimes it's at odd hours of the night, different shifts, some of those items. And so we looked at the staffing challenges and then also just the current call center operations. Are we able, have costs gone up? What does that look like? We know that that answer is at least a little bit relatively yes, they have, but do we need to switch focus? Do we need to take less from marketing, more from marketing, et cetera? So one of the things here at the bottom of the page, the last thing I'll mention here on this slide was we did have the 988 Coordinating Council recommendations for fiscal year 26. And this was to change the 988 funding mechanism to be able to roll over the funding to continue support for the 988 initiative. So we wanted to make sure that this committee, if you weren't already aware and hadn't already seen that in some of your other committees or business, that you were aware of that as well. And I think with that, Mr. Chair, members of the committee, I can stand for questions at the appropriate time.
Thank you very much, Drew. Are there any questions? Yes, Representative Berquist.
I'll be real quick. Thank you for your testimony, and thank you, Mr. Chair. Is there a very consistent training across 988 for across the country, the way that the calls are handled, and is there a consistent training for everybody?
So, Mr. Chair, Representative, we actually do, and I checked before this, we actually do have a provider here from Health Source, formerly was with headquarters. So I might ask if it's okay if I bring Monica Kurz up from Health Source Integrated Solutions to speak to that. Is that all right?
But maybe when.
That would be fine. Monica, if you'd like to come up, that's fine.
Thank you.
Hello, Monica Kurz. I'm the Chief Administrative Officer with Health Source Integrated Solutions. As Drew said, I work with the 988 line and have for a number of years now. So to answer your question, Representative, there is consistent training across the system nationally. So Vibrant Emotional Health, who administers the Lifeline, makes online training available to every center and requires that any counselor who's going to answer phone calls, texts, or chats complete those trainings. Involved in that is completing at least 8 role plays so that they have some kind of on-the-ground experience. Now, Health Source, as well as every other center in Kansas, we do additional training to that. As Drew said, we try to be very creative with making sure that we are providing high quality, highly trained folks to answer this line, but we want to make sure that the opportunity is really wide open, which is why we place so much emphasis on building that competence in-house. So we have a training coordinator who I actually think is going to be training a new cohort of employees starting next week. So we're kind of doing that throughout the year in addition to what they do nationally. Does that answer it?
Yes, and just one follow-up real quick. About how long, is there an average time for how long a call takes? Success or not, but yeah.
Yeah, no, excellent question. Thank you for that. So our phone calls, I believe, are on average about 26 minutes is that kind of average time. Now, it's important to note with that, some calls will last 5 minutes and some will last 90. So we're truly talking about an average there. We do find that the time invested for a text message conversation tends to be longer. Those conversations are about 45 minutes. And if you think about it, it's pretty logical. If you think about how you text, it just takes a little bit longer for those messages to go back and forth. You may get interrupted on the caller side for doing those. So we do find that those take a bit longer than the phone calls.
Thank you. Thank you, Mr. Chair.
Thank you. Monica, just quickly, you work at a call center, right? These are not people at home on the phone. It's call centers 24/7.
Yeah, so we have kind of a variety of modalities across the state. So headquarters, Johnson County, and ComCare are all full-time in the office call center. And then HealthSource, my organization, and I believe Wyandotte County as well, is able to offer a hybrid option for our folks. So what that means is that they are able to work from home if they want to, if they're able to provide a HIPAA-compliant private area in their home to take those contacts, and if they have a reliable internet connection. So we have found that that has been helpful with our workforce challenges, being able to offer that hybrid option.
And just real quickly, you mentioned the training requirements. I assume there's quality assurance and continuing monitoring of calls and et cetera for quality control.
You would be correct. So there's a national standard that we're doing quality control on 3% of our phone calls and 1% of those text online chat conversations. Our goal at HealthSource is to exceed that number, and I'm happy to report that we have been. So in addition to that number of phone calls or conversations that we're providing quality assurance monitoring on, there are also metrics that are provided to us nationally so that we're looking at the quality of those calls, what kinds of behaviors do our counselors have, what are our outcomes, are we doing safety checks, those kinds of things. And that's also helping with that consistent service standard across states.
Thank you, Monica. Representative Bueller.
Thank you, Mr. Chair. And the first one might be for Monica or.
That's all good.
Okay, and then I have a second follow-up, so please don't run for it. So when we were talking about the Lifeline options, and there's the Veteran Spanish and the Trevor Project, and then the Remain Online. So my question is, so I know for veterans, in my Navy life, we would direct people to Military One Source for all suicide-related things. Do you roll into organizations like Military One Source through the 988? I'm asking about affiliated partners, I guess, and does that exist for each of these three categories?
So each of the three categories, those kind of press number options, are all operated by a sub-network. So for veterans, that's a Veterans Crisis Line. We have a center here in Topeka who answers, and then I believe there are 4 other centers associated with VAs that answer that. So that's an optional self-identification as a veteran, saying that you want to talk to the VCL. I will just take this opportunity to point out that we do talk to veterans on our local lines. Sometimes folks don't want to talk to the VA. So that is operated by the VA. The Spanish sub-network is associated with 988, but that is a smaller number of centers who are able to offer 24/7 Spanish language services, which is not something we're able to do here in the state of Kansas. So there are these kind of sub-networks. There's also a deaf hard of hearing sub-network where they're able to offer video chats so that they can provide services in that way. And I believe those are primarily out of Missouri. So they're kind of spread around. Does that answer the question?
It does, and thank you, if I may, Mr. Chair. One of the reasons I'm asking the question is it kind of rolls into the second part of this, which is funding. So I don't know if there is if there's any funding transfers, or if it's, let's say it's Military One Source or the VA. Is there any contribution by that sub-network in terms of payment or cost?
All of the sub-networks are federally funded. So
no additional, I guess, so no additional state funding. Okay.
No, we wouldn't.
Okay.
We wouldn't, sorry. Mr. Chair, members of the committee, you're correct. We would not receive that. They have their own lines of funding for that. Again, this is the national option whenever you're going through. And so that wouldn't impede on or take from our fund that we have, if that, the 988 fund for the state of Kansas.
Okay, so that helps. And that kind of gets me to the second part of this, and I'm hoping I didn't miss this, but when we talked about when you want to change the funding mechanism for all remaining funds to roll over into next fiscal year and to keeping that cap at 10 million, was that part of the budget request that KDAD's made? With that specific language? Because I don't remember that.
This would,
I just want
and
to
I will double check that. Mr. Chair, members of the committee, representative, thank you for the question. I will double check that. My understanding is that that came specifically from the coordinating council, so it's a little bit more of a quasi, but I will double check that.
I see Lee. Thank you.
Hi, Lee Kack, Director of Governmental Affairs for KDADS. It was not part of the agency's enhancement request. That was a recommendation from the 988 Coordinating Council.
Okay, so I just want to make sure that I have this in front of me to make sure if this is going forward, that we either don't lose sight of it or we have the proper legislative mechanism in place to handle this, if that makes sense. So,
Certainly, and I think that the reason it was not included in the agency enhancement request, and I know that Secretary Howard addressed this during the budget hearing, we were under the impression that for this coming fiscal year, additional funds would not be necessary, but do appreciate you keeping that on your radar as the text and chat capabilities are becoming more in play with the system. There will be upgrades needed and additional capacity, so it is a good item to keep on your radar.
okay. Thank you, and thank you, Mr. Chair.
Very good. Representative Blex.
Thank you, Mr. Chair. Thank you for your presentation. When you made the statement, all calls are answered within 2 minutes, is that to a real person, or is that something ringing before it actually gets into a system of veterans and punch numbers? How's that work? Because I hope I never call you.
So if Mr. Chair, members of the committee, representative, if I'm understanding your question correctly, the answer would be yes, it is answered by a real person. When you first call, you will be prompted, but once you have that selection, you would be talking to a live individual.
Okay, follow up, if you may. The 10%, the 4,000 that did not get answered, what was the reason for that? They just hung up, or was there not enough staff, or do you know any reasons why they weren't answered?
There, Mr. Chair, Representative, there are a litany, there can be a myriad of reasons. A lot of what we see at the state is that they can be discontinued for individual not needing that service any longer, deciding to hang up the phone. It can be that the rollover, whenever, if we didn't have enough, so say if it is telephonic means by communication, if that is taking too long to get them to the local crisis center, they may hang up the phone call there too. Could be staffing. I don't know that we're seeing that as much on the telephone side again as we are on the chat and text, but there are some specific, there are some reasons for that, and we can try to mine some of that data to be more specific if the committee would prefer.
Okay, thank you for that. Thank you, Mr. Chair.
Representative Rivas.
Thank you, Chair. I've got a couple of questions for you, if you don't mind. One kind of ties into what Representative Blex was talking about with the abandoned ones, or whatever you want to call it. Is there any kind of follow-up with those? Is there any way you track those? Or, I'm just thinking if someone's on there and they get frustrated, but they still have a crisis. So is there any kind of a plan in place for that?
Mr. Chair, Representative, it is pretty tough to follow up because this isn't an identifying service for the individual, right? So to be able to keep that privacy, to make sure that they feel vulnerable enough to be able to come forth and call in the first place. Now, I did mention geo-routing beforehand, so again, that's de-identified information, but that would be a little bit more local. So to my knowledge, I don't believe that we have a way to identify for follow-up, as you have mentioned.
Okay. And just one other, if you don't mind. So I know this is still a kind of a growing process as far as awareness and utilization. So do you have any benchmarks for where Kansas, based on its population demographics, should end up as what is considered kind of our normal flow of these kind of calls?
I think, as I mentioned before on slide, well, on a few of the slides, but definitely on slide 7, we're always aiming for those in-state answer rates to be above 90%. We feel like that is a very good, both nationally, but a good average for the state of Kansas to be searching for. I mean, we'd love for that to be at 100%, but I don't know that that's necessarily realistic, at least for where we're at. For the chat and text function, I would say that would be about the same. Anything above 85% is also nationally, I think, average still pretty good. So that's the main measure and metric by which we're able to gauge our success at this point in time.
Can I ask? Yeah, I probably wasn't clear on that. So let me go back to that. Okay, 47,160 originating in state. Is that the normal volume you think we'll have, or do you think in 2 years that should be 70,000?
Right.
That's what I was asking. Is where are we getting maximum penetration to really get the need met?
Mr. Chair, Representative, thank you. I apologize for the confusion. We do expect for that number to go up. Part of that and part of the reason for some, I believe some of the recommendation from the council is to be able to get more funding out the door for marketing and awareness. We still have individuals that are calling 911 for these types of services because specifically they don't know about 988. If you go out and talk to probably 10 people, I would be shocked if 4 of them really knew what 988 is and also how they could access that for a loved one. Part of that is because we have a lot of different phone numbers for a lot of different things. And so we're really trying, one of the federal grants that we just received, we are looking at a way to get a position for our agency to focus specifically on 988 and 911, who I think, I don't want to say competitor, right, but is definitely that other line that most people feel comfortable calling, so that we can boost our services and our coordination and collaboration with that. But yes, Representative, we do expect for that number to go up. I don't have a number right now, but I'm happy to get that to you as we plan that out.
Thank you. Just quick follow-up on that. If someone calls 911, do they ever triage to the 988, or do you coordinate that way, or do they just do EMS stuff?
Representative, Mr. Chair, I might ask Monica back up on that too, just to see if she has any examples of that.
Thank you. I just want to repeat the question, make sure that we're on the same page. You're wondering if someone calls 911, that would be appropriate for 988. Are we seeing transfers there?
Well, do they transfer the call to 988, basically?
Yeah, so we actually see calls transfer both ways. So if we have someone who calls 988 who requires medical attention or a law enforcement welfare check, we will transfer to 911 and coordinate with that public service answering point. We also worked with the 911 Coordinating Council to ensure that every 911 public service answering point in the state of Kansas had a direct transfer button within their console to be able to transfer phone calls that are coming into 911 that don't have a medical or criminal component to 988 so that we can do some of that more supportive counseling, hopefully de-escalate those situations. I will tell the committee that we certainly have work to do there. The capability is there. We see it happen at times. We could do it a lot more. And I think that that's where you're hearing the agency say that if we had some more resources to really think about how to increase the confidence of the 911 call takers in 988, since it is such a new service to them, I think we'd see that utilized a lot more.
That's very good. Thank you. Representative McDonald.
Thank you, Mr. Chair. My question's for Drew. I really appreciate all this detailed, the detailed metrics you provided. I did have one question, and forgive me if you covered this during your presentation. I might have zoned out for a second there eating my lunch. But from March 24 to August of 24, and then starting again in December of 24, it looks like we've dipped below the national answer rate, average monthly answer rate. Do you have anything you attribute that to? And do you see that, when we dipped in December, do you see that as a trend that has continued, or is it too soon to know?
Mr. Chair, Representative, thank you for the question. Are you referencing slide 7? Is that correct? I just want to make sure we're looking. I'm assuming it's the in-state call answer rates.
Yes.
Okay. And just paraphrasing your question back to you, curious about any trends that we saw that attributed to that both in May and then in December as well.
Well, it was March through August of 2024, and then it looks like in December it
Okay.
happened again.
Just the continuous, a little bit more of a declination and decline there.
Yeah, we just didn't measure up to the national average, I guess, according to
So I don't know, outside of some of the things that, Mr. Chair, Representative, that I can speak specifically to exactly what might have caused that. I can tell you that truly workforce has been one of the biggest barriers that we continue to see. And so finding people that can handle being able to be a trained professional for these calls that they're getting. Again, we're dealing with individuals that are in crisis. It could be at 3 in the morning. It could be at 3 in the afternoon. I think that seeing that, also being able to look at the $10 million that we have and adjust funding based on needs for workforce and resources, space, any other equipment, those types of things. Those are things that we're still learning as an agency and also looking at the advisement and consent of the 90-day coordinating council. So I think a little bit too early to know, but what we do know for sure is that workforce has attributed that, at least some.
Okay, could I ask one follow-up question real quick? I always worry a little bit about PTSD from our first responders and people who might experience trauma secondhand. And I could imagine people who answer these calls could be put in a position like that. Is there something built in that gives them the ability to get counseling if needed, or some time off, or restructured if they need a minute to regroup from hard calls or that sort of thing?
So, Mr. Chair, members of the committee, representative, that's a great question. I do know that at least half, if not all, of our call centers, specifically like headquarters and then also Health Source, they do have those mechanisms built in, those times to be able to take individuals. I don't know that I can speak specifically to like a crisis counseling or a counseling that they would have there, but I do know that they have measures to be able to take people so there isn't trauma, there isn't PTSD, and there isn't burnout from that as well. They have some of those things that are built in, and that some of that is also, it's not contractually obligated, but it's stuff that we expect to see from our providers that we contract with.
Okay, thank you. If there's a measure of that, that would be something I'd be interested in. Thank you very much.
Thank you.
Okay, good. One more question before we move on. Representative Berquist.
Maybe real quick. How many states are involved in this whole program?
Mr. Chair, Representative, I believe that is all of them, but I would have to verify that. I believe in some way, shape, or form that all states have at least moved or taken a step into the 988 realm.
And my follow-up and the reason for my question is some states are more prone to and have laws to legalize euthanasia. And does that play into how they answer the call? If somebody's calling about a physical ailment and they're thinking about killing themselves, would that kind of counseling change from state to state? No, she says no. I'm good with that. I like that. No,
that's good. That's Mr. Chair, Representative. That's why we like to have our providers here. I'm very thankful for our providers to be here to provide that frontline experience too.
All right. Thank you, Mr. Chair.
Thank you, Drew, for that. And members of the committee, we have another presentation now. Some of the older guys on the and gals on the committee know about MHIT. The mental health intervention team program. For those that are new on the committee, this will be a good overview for upcoming hearings. And so we have Drew Atkins once more for the mental health intervention team program.
Thank you, Mr. Chair, members of the committee. Good to see everybody again. Truly very thankful to be able to share this information with you. We have, over at ks.gov, we have inherited the Mental Health Intervention Team Program, also known as MHIT. That's how I'll reference it throughout the presentation. We have inherited that program now just after the previous legislative session. So a little bit under a year now, but we've seen tremendous success, and we're thankful for that. We've been thankful for the Department of Education here in Kansas. They've been great partners in this transition to help us and make sure this flows smoothly for all of our USDs and also our private schools, which is a new piece of this, and I'll get to that throughout my presentation. So in the, oh, I'm sorry, pardon. And is that you or is that me? I'm sorry. That was me, but I think you should work. I should, okay. Yeah. There we go. All right. So, Mr. Chair, I'm going to start here with the first slide just to do a program overview in the history of MHIT in the state of Kansas. And so the overview is that MHIT, we have, it's a multidisciplinary approach for the kiddos in school for mental and behavioral health services. We have school districts that receive funding now from the state from KDODS, formerly from KSDE, that would allow them to hire school-based liaisons at the school. This liaison would act in between the consumer, in this case, the kid there at the school, and then also our mental health providers that are outside of the school district to be able to connect them to any of those behavioral health services that they need. And so whenever we started here, I think back in, you'll see this, we have this back in 2018, we started with a pilot program that has been renewed year after year through proviso language. I am happy to say, I'm very thankful that we do have a hearing coming up for House Bill 2236 next week for this to be enshrined in statute, and I'll talk a little bit more about that and pepper that throughout my my presentation as well. The original pilot and the proviso from 2018 authorized 9 school districts to enter into agreements with their local community mental health centers to provide those school-based services. Today, we have over 130 schools, and we employ over 240 SBLs or school-based liaisons throughout the state. They partner now not only with our community mental health centers, those are also known as our certified community behavioral health clinics, but they also partner with several federally qualified health centers or FQHCs, and then also some private providers. I think it's important to note that we do have some legislative mandates for this program that we have to follow for the services that are in the proviso language and renewed year to year. And all of those services must be provided in person, face to face. We do not have any services at this point in time that are provided telehealth. Some of those services are provided 24/7, 365 days of the year. Some of those are crisis services that are required to be able to be applicable and accessible by the student. Some of the others are therapies and also some family therapies and family rehabilitation sessions between the family and the student and the mental health provider. So I mentioned this previously, but this is just a better visualization on who is involved and who are the key stakeholders in the program. So we have our MHIT student at the center of this. We also have our family guardians, family that's involved. Engagement is very essential to the program's success. We have our mental health providers, so we have therapists, case managers. We also have medication management, medication services that are available. There is a requirement for 24/7 crisis services. I mentioned that. And we also have on-site family therapy that's offered. But also in this, we have school staff that we really need, and we hear about this all the time anecdotally from the students and also the providers, that the school staff are tremendous to work with, and they're very crucial to this process. That goes from superintendents to teachers. Obviously, the school-based liaisons are at the center of this with the student. Any coaches, any bus drivers, any of that support staff that really help the student get the assistance and services that they need. There we go. All right. So mentioned a little bit about this earlier. Any of the MHIT participating USDs or the qualified schools, the private schools that we had just added in this past legislative proviso, select their own mental health provider that they would like to work with. That mental health provider must provide all of those bulleted services, and I won't go through all of those, but again, I think one of the biggest ones is that they have to have 24/7 access to crisis care and have that care coordination for that and emergency response services. They provide outreach, participate in the treatment planning process. They also make referral to other appropriate community services. So if there are primary care needs, some of those other items, and they're not working with an FQHC in the area, they can get coordinated care for that and referred into that as well. All right. Talking a little bit more about the numbers here, Mr. Chair, members of the committee. So the MHIT funding structure, this did change in the latest proviso. The MHIT grant awards each USD 100% of their school-based liaison salaries, so that is paid for with the grant that they get. The USD retains 65% of that funding to cover Part of that, and the USD passes along 65%, or I'm sorry, 35% of the awarded funding to the mental health provider. And so the funding, I apologize, going back to number one, they provide 65, we provide 65% of that funding structure, and then they provide the 35% to holistically pay for the school-based liaison. My apologies there, Mr. Chair. The SBLs, they can work in each different school within the district, but a lot of the time, if we have many schools that are in that district, they may be assigned to multiple school buildings in that district. So they may work across the span of each of that district that they're with the USD or also the private school. This is something that we wanted to include, and we've presented on this, I think, once or twice since we've inherited the program, but one of the biggest quotes that we have, and on this slide over here on the left, is that we had a quote from an MHIT student that the therapist that they had saved their life. This isn't the only quote that we have like this. We also have quotes that they've given them the ability and the courage to go back into school and feel confident about being back in school, and that's one of the reasons that this program is very necessary, and we're thankful for the funding to continue the program. All right, so one of the key indicators of growth and success is a benchmark that we wanted to provide. We were able to get this from our colleagues over at the Kansas Department of Education, were improved attendance, improved externalizing behavior, improved academics, and improved internalizing behavior. This is from the school year for 2023 and 2024. We had 74% of students that had improved attendance. We had 70% of students improved externalizing behavior. We had 70% that improved academically, and then also 70% that improved internalizing behavior. And we do, Mr. Chair, members of the committee, we do have some representatives from the Department of Education if there are further questions of that at the end of the presentation and how that's measured. So on slide 8 here, these were responses that, again, going back to the 2023 and 2024 school year for MHIT schools. These are some of the responses that we got when the questions were asked about what did the school administrators and teachers and school staff like most about the MHIT program. Again, I won't go through each and every one of these. You should have those in front of you. But things like addressing the behavioral challenges with our schools, freeing up the valuable time for our teachers to focus on teaching. The students are seen by licensed therapists at their school during the day. Again, this isn't something, this is a personal and tangential or tangible relationship that they can have with their therapist, with their school-based liaison to feel comfortable about that. It's something they can have in person and face-to-face. We had, one of the other points that I wanted to make is that we had a comment that it saves the families of the school district and some of the things that they've been saying, the time and effort, and some of the other things that we see at KDADS or some of the kiddos that haven't been able to access some of these services, just whether or not we haven't been able to expand into those schools or not. And so these kids are sometimes having to be taken out of school, being served in our psychiatric residential treatment facilities. So again, this is a huge piece of some of the success from the students that are served by this program. All right. And so these are just, again, by the numbers. I mentioned this in the first slide as well. We're in over 130 schools, 130 plus of MHIT schools. We have 240 school-based liaisons employed throughout the state. We had 15,000 plus students provided comprehensive behavioral health services in a school-based setting since the inception of the program in 2018, as it came out of that proviso language. One of the this goes back again on the MHIT and on the MHIT program and how it actually came to the agency from KSDE, Mr. Chair, members of the committee. I mentioned about the funding. I believe that used to be a 75% to 25% split. Obviously, the funding did transfer from KSD over to the Behavioral Health Commission within KDADS. A couple of the other things that I wanted to hit on here were the MHIT award to retain, the $13.8 million to retain its existing USDs. We've seen tremendous success in that with the transition of the program. Again, we could not have done that without the help of KSDE and also having staff that are specifically have been in this program that we inherited from KSDE, so we're very thankful for that. We had a total of about $4.5 million to expand and fund new USDEs, and we continue to look at that and do some business development there with the unified with the USDs there. We also got we got $1.5 million in startup funding for qualified schools, and so private schools are now able to access these services and pair up with a mental health provider, which is huge, and we've seen a huge increase in applications and awards from that. I'll speak a little bit more about how we were able to deliver those awards, but we've seen a very big number of those dollars that have been claimed by private schools, and so we know that that is a much needed service in that arena. So I mentioned earlier the qualified school. So this is in the proviso language. You all may have already seen that, but if not, this is just as defined by the legislature, any non-public school providing education to elementary or secondary students and is accredited by a state board, a national or regional accrediting agency, recognized by the state board for satisfying the teaching performance assessment for professional licensure and or is working in good faith toward such accreditation. Pardon me. So in the legislative proviso that created the funding for the qualified schools and their participation in this program, what was born out of that is a 7-member MHIT qualified school board that is appointed by the KDAD secretary, and the requirements of that board are listed below. And so mainly they do meet, and we have had them meet to get these most recent awards out. They meet and they review those applications that we get from those qualified schools. And so we were happy that that was able to get up and running. I believe we got that board together pretty briefly after the legislative session, and this was inked into the budget this past year. And so we continue to find a lot of strength in working with the qualified mental health school board. There are specific individuals that are named in there. We have to have a qualified mental health provider. There must be a representative of the community mental health centers and the Association of Community Mental Health Centers, also for the federally qualified health centers. And so we have a diverse representation. Also, we have to have a consumer from that arena. And so, again, we've seen tremendous success and very proud of where we've been able to get with that. All right, Mr. Chair, members of the committee. So slide 13, we're going to look at just, and I won't go over all of these, but I might hit on each of the areas that we have some program successes for the KDAD's MHIT program from 2024 to 2025. So that first bullet point there for existing schools, that we've had a 97% retention rate of existing USDs that have signed back up for the program. So again, we're pretty proud about that, especially with a transition, an agency transition. In the qualified schools, we have had 21 schools that have been approved for that. They've employed 17 school-based liaison, and all the applicants who applied were awarded funding. Looking ahead into the future, some of the expansion USD dollars that we have, 6 expansion USDs, employing 17 school-based liaisons. We do have a second round of those USDs that are looking at currently applying for the program. Some of the feedback that we have got is some of the hesitation that this isn't in state statute right now. So the worry would be that they might hire a school-based liaison and invest those dollars for that service and not be able to pay them in subsequent year. I believe This is our 2025 legislative session goal. It goes over some of those metrics and those numbers that I mentioned below. Again, just to furthermore, and not to lament, but we have served over 15,000 students since this program has come on board. We continually hear from the providers, the schools, and also from the families about how important this service is. We're very, very thankful. We're enthusiastic and excited to continue this work with the MHIP program as we move forward. And with that, Mr. Chair, I will cede my time back, and I'm happy to answer questions as appropriate.
Very good. Any questions from the committee? Representative McDonald?
Thank you, Mr. Chair. I have 2 or 3. Do you have metrics on the number of public schools versus private schools? I know on slide 13 you mentioned 17, I guess you call them qualified schools. Do you know, I'm curious what the ratio is between that and the number of USDs.
Mr. Chair, members of the committee, I do believe that we have that, and I can supplement that for the committee. I don't believe I have that. I'll look through my information, Representative, but I don't think I have that off the top of my head. I'm sorry.
Okay, and then the other 2 items I'd like to know is the number of students in public schools served versus private schools, and the number of dollars spent servicing public school students versus private school students. If I could get those, that would be great. Yeah. Thank you.
Thank you.
Yes, Representative Oropeza.
Thank you, Mr. Chair. My question is, with the 13 million, is that all SGF, or is that matched federally at all, or how's that broken up? Thank you.
Mr. Chair, Representative, thank you for the question. That the 13.8 million, that is all state general fund dollars, yes. That is not matched federally for the service.
Okay, thank you.
Representative Blex.
Thank you, Mr. Chair, and thank you for your program. Do you see the possibility of large school districts having their own APRN that would be qualified in mental health doing that? I realize they have a 24/7, and it was designed for the FQHCs and the community healthcare behavioral clinics. But do you see some of that of possibility of having us on staff in some of those large school districts or not?
Mr. Chair, Representative, that's a great question. I think hypothetically that could be possible. I don't like to usually speak in hypotheticals. I think that what we do know at the agency is that some of the federally qualified health centers do have a larger presence, and that can be in those school districts. I don't know if they employ an APRN or a nurse practitioner. I think it's certainly feasible personally, but I don't know that I could provide any more insight on that as it relates specifically to the MHIP program for some of those primary care services.
Thank you for that.
Representative Steens.
Thank you, Mr. Chair, and thank you for your presentation on both the 988 and this, the MHIP. So I'm very new to this. I'm new to this committee. Quick comment and then a question. I think that's great that you do have private schools that are also optional for this because, you know, we're all paying taxes, whether it's in our private and our public schools. So I think that's very important. My second question is, and maybe you mentioned it because I was looking at the costs. So are these kids that are getting these services, are the parents also using their own private insurance to pay for this as well? Okay, so this is all funded through this program.
Mr. Chair, Representative, thank you for the question. Yes, this is all these services that they are getting for the school-based liaison. So again, the care coordination and the connection with the mental health provider, those services are all paid through this funding. Now, if there are subsequent mental health services that they need, they can work with the mental health provider or be referred to the appropriate services. And that's where the question about insurance and the coverage, if they have Medicaid, private, TRICARE, something like that, or if they're uninsured, right, how can we maybe get them eligible, if they're eligible, right, to get covered. So the answer in short is yes, but it doesn't cover those further services outside the getting connected. Does that make sense?
Yes, it does. Thank you very much.
Mm-hmm.
Representative Weichel.
Thank you, Mr. Chairman. And I have a follow-up to Representative Steen's question because I wasn't here last year when this passed. So just to clarify, so if a child in school is receiving mental health services through this program and that child is enrolled in Medicaid or private insurance, they're insured, is their insurance billed for that encounter in the school?
Mr. Chair, Representative, we may be wading into some Medicaid waters, and unfortunately, I'm not a Medicaid subject matter expert. I'm happy to take that back. Again, my assumption is that no, because it's going to be based on location of service or place of service, but I'm happy to provide that follow-up and get with my colleagues at KDHE on that.
That would
Yeah.
be good. Representative Weichel.
Yeah, sorry, thank you, Mr. Chair. Yeah, I think that would be great because I think when we think about the SGF funding and how we can maximize other funding sources to use some of that, that's an important question to understand.
Happy to follow up on that, Mr. Chair.
That'd be great. Any other questions? Representative Bueller.
I carried this bill a year ago, so the way I look at this is it's triage, mental health triage in the school system. The school districts don't have to participate. So I know in my district, for example, the two largest one, only one participates. So if you think about your guidance counselors that have some kind of mental health aspect to it, and the Association of Community Mental Health Centers, I get that acronym screwed up. That's kind of the partnership. So it's that initial triage with if your school district wants to participate and be part of the MHIT program, that's how the services kind of start and initiate. And beyond maybe this is not the best term, that triage of initial care, then other options are explored that might eventually require insurance and other treatment. But think of it as triage in the school district for mental health, if that helps. Thank you.
I think that question and Representative Black's question got me thinking. Do I understand right that the mental health providers are not prescribing medications? It's counseling and so forth. They are not providing medications in the MHIT program, correct? They're referring to the CCBHC and that sort of thing.
Yeah, so in the school, I think in short, Mr. Chair, your answer is yes.
Very good. Any other questions? Drew? Oh,
thank you.
Oh, one more question, Representative Turner.
Well, I was looking at, thank you, Mr. Chair. I was looking because I thought I saw medication services listed in one of your slides, right?
Right. So, Mr. Chair, Representative, to delineate a little bit further, right, that wouldn't be necessarily inside the school, right? That would be after an assessment and intake is done at the behavioral health clinic, as the chair mentioned earlier, if that makes sense, Representative. Medication management, Mr. Chair, Representative, medication management is one of the many services that the Certified Community Behavioral Health Clinic, also some of the federally qualified health centers and other private providers do offer to their consumers.
So the only person in the school is the liaison, like one per school?
Mr. Chair, Representative, yes, it can be one per school, yes.
Or it could be more?
Mr. Chair, Representative, mostly, to my knowledge, it is just one. A lot of the time, because of how they are funded and the need, they are spread amongst many schools. They can be spread, multiple, I should say.
Okay, and so the time that the children are out of the classroom, and is that class time made up, or how do they work that side?
Mr. Chair, Representative, I don't know that I have a complete answer on that, even anecdotally, but I'm happy to try and provide an example back to the committee if you would prefer that.
Okay, last question, sorry. On the money side, the 13.8 was thrown out, but it's 13.8 plus 4.5, so it's 18.3 total, correct, is for the amount this year?
Mr. Chair, if I can get to my notes really quickly, I'm sorry.
Yeah, it's your slide 10.
Yes, so that's correct. So the 4.5 is the number for the expansion so that we can build out and develop more school districts to be able to come into the program, Representative, Mr. Chair.
All right. Thank you, Mr. Chair.
Just one last thing that clears up something for me. When you used the term mental health provider, that wasn't necessarily someone at the school site. That is the CCBHC or the FQHC, correct?
Mr. Chair, yes, that is correct.
That helps me understand. Thank you. If there are no other questions, thank you so much, Drew. Both of these programs seem to be very, very helpful. I appreciate that.
Thank you, and thank you to the committee for having us.
Committee, if there's no other business, we will be adjourned. Thank you. There's no meeting tomorrow.